Hello, this is Charles Clinton. Don't hesitate on pausing the video in order to see all the different PowerPoint slides. I will go pretty fast since YouTube does not permit more than 15 minutes. So this is a summary on chapter 92, Neurological Disorders and Cardiovascular Disease, Braunwald's heart disease. What are the diseases we will see here? Mainly the muscular dystrophies that are associated with cardiovascular disease. We'll see them one by one. Duchenne and Becker. Both of these diseases affect dystrophin, the dystrophin gene, the mRNA. This means that you will make less dystrophin. It is X-linked recessive, and if you have a total absence of dystrophin, you will have the Duchenne subtype. Duchenne is the most frequently inherited neuromuscular disease. 1 to 3 persons per every 6,000, and there's complete absence of dystrophin, which means that the disease is more severe. Patients will usually die before age 25. While in Becker, there's reduced dystrophin and patients usually die around 40 to 50. What will you see in these patients? You will see dilated cardiomyopathy in almost 90% of patients aged 20 years of age. Then other alterations or changes in the cardiovascular exam will be mitral regurgitation, a grade 1 to 3 out of 6, and Duchenne it's by posterior papillary muscle dysfunction, and Becker it's by mitral annular dilation, and second heart sound will be louder. EKG, tall R wave in V1, deep narrow Q in D1 and AVL. Why this Q wave in D1 and AVL? Because this disease likes affecting mainly the inferobasal and anterolateral walls. There you can see it in the red circle and red rectangle. They may have arrhythmias, which tachycardia would be the most common arrhythmia, but these patients mainly have dilated cardiomyopathy. Treatment and prognosis. There's no good treatment for this. Steroids may delay muscle and cardiac progression. And myotonic dystrophies. Look at these people in the picture. The lady in the center, white hair, doesn't have the disease. All those around her are sons, daughters. They do have the disease. They have a thin facies associated with myotonic dystrophies. It's autosomic dominant inheritance pattern. There's reflex and percussion myotonia, and there's weakness and distal atrophy. There's two types, type 1 and 2. Type 1, myotonic dystrophies have trinucleotide repeat expansions. It's CTG, the codon that is repeating itself. And in type 1, it's the most frequent, and it's worse than type 2. If you see on the left, type 1, the more repeats you have, the worse for the patient. In type 2, the number of repeats is not associated with severity. In the middle, you can see myotonia. Myotonia is a difficulty in relaxing from contraction. That's what you see there. On the right, you can see fibrofatty infiltration and atrophy. Here you can see the clinical spectrum of these patients. Myotonic dystrophy is the most common inherited neuromuscular disorder in patients presenting in adulthood. Why in adulthood? Because Becker and Duchenne patients have already died by this time usually. And you have that in In general, the diagnosis in asymptomatic patients, you can do an electromyogram and genetic studies. Okay. Cardiovascular manifestations, mainly arrhythmias. Here you'll find mainly arrhythmias. In type 1, you'll see 65% of patients with abnormal EKGs, and in type 2, only 20% abnormal EKGs. Echocardiographic findings, diastolic dysfunction that usually precedes systolic dysfunction, left ventricular hypertrophy, left atrial dilation, mitral valve prolapse, and regional wall motion abnormalities. Prevalence of clinical heart failure is pretty low, only 2%. And the arrhythmias are usually secondary to his ventricular prolongation. Many of these patients end up with permanent pacing, and this is a good indication since they could do sudden cardiac death. These are alterations you can find here with prolongation of conduction and patients doing ventricular tachycardia, ventricular arrhythmias on the right. This is an electrophysiologic study showing how the patient has a ventricular arrhythmia. And now the Emery-Dreifuss muscular dystrophy and associated disorders. This is a pretty rare disease, affects skeletal muscle mildly, but cardiac involvement is usually life-threatening. So this is scary. Not much skeletal, but pretty severe on the cardiac side, and this produces death usually. So it is X-linked recessive, but there's heterogeneity in the mode of inheritance, mainly X recessive. The gene is STA, which encodes for emerin, but there's also other genes found which are on chromosome 1, which are lamins A and C. Emerin and the lamins give structural support to the nucleus and interact with cytoskeletal proteins. There's a clinical triad in these Emery-Dreifuss. 1. Early contractures of elbow, Achilles tendon, post-cervical muscles. 2. Slowly progressing muscle weakness or atrophy. And 3. Cardiac involvement. It's usually known as benign X-linked muscular dystrophy to differentiate the slowly progressive muscular weakness from Duchenne. This is, of course, not benign at all, but comparative to Duchenne, if people can live 10 to 20 years more, it's probably benign. And the definitive diagnosis, genetic and anti-emerin antibody staining in skeletal muscle. Okay, here's a picture of what we're talking about. Here's Emery-Dreifuss showing us the atrophy of the muscles in the elbows, also in the humeral part, and here we can see the EKG alterations. Let's see. EKG is abnormal in most patients 20 to 30 year old. It is common to see a first degree AV block, and there's mainly problems with the impulse generation or conduction abnormality in all patients aged 35 to 40. This is the main problem in this in EKG is impulse generation or conduction abnormalities. You have to monitor these patients for arrhythmias if there's conduction disease present, permanent pacing indicated. Lamin A and C as well. You can give these patients prophylactic ICD. Now the limb-girdle muscular dystrophies. The most common is type 2, which is autosomal recessive, and least common is autosomal dominant type 1. And it's associated with dystrophin-associated glycoproteins, sarcomeric proteins, nuclear membrane proteins, and cellular enzymes. Clinically, what can you find here? You can find that the recessive pattern inheritance has earlier manifestations and is more severe. There is creatine kinase moderately elevated, and there's facial sparing. That's why you see no face or facial in the name of this disease. It's limb-girdle. Cardiovascular, there's heterogeneity. There's different types of this disease. Type 2, C to F produce dilated cardiomyopathy and EKG findings similar to Duchenne. Type 2I is related to fucotin protein in chromosome 19, and autosomal dominant 1B is associated to lamins A and C. So this reminds us of EMERY-DREIFUSS, which was mild skeletal manifestation and severe cardiac conduction abnormalities with arrhythmias, with ICD prophylactically. Here we can see the dilation and also the moderate systolic dysfunction. Treatment and prognosis, it's based on the genetic classification. Now let's go to facioscapulohumeral muscular dystrophies. See here in the name it says fascio, so it affects the face, and it also affects the let's see, face and shoulder, and then affects the pelvic area. Disability for walking is produced in around 20% of patients. Facioscapulohumeral muscular dystrophy does not affect the heart in general, but if it is associated with the heart, think about atrial arrhythmias. You should do annual EKGs in these patients. This is the third most common muscular dystrophy. Number 1, Duchenne. 2, myotonic dystrophy. 3, facioscapulohumeral muscular dystrophy. Friedrich ataxia. Friedrich has 9 letters. It's associated to chromosome 9. Ataxia starts with an A, and Friedrich has 2 R's. It is autosomal recessive, associated to frataxin. Frataxin, it has to do with free radicals and also with iron management in the cell. When you have frataxin, which is produced in less or dysfunctional, in a dysfunctional manner, you will see a poor cellular response to oxidative stress and also apoptosis. So this disease is a trinucleotide repeat expansion of GAA, and it is the most common inherited spinocerebellar degenerative disease. It is associated with dysarthria, ataxia of the limbs, loss of deep tendon reflexes, sensory abnormalities, skeletal deformities, diabetes, and cardiac involvement. Okay, so these patients may produce or have hypertrophic cardiomyopathy, but this hypertrophic cardiomyopathy is less arrhythmic than the usual inherited hypertrophic cardiomyopathies. Here you have frataxin going crazy in the cell, and here you can see what happens in the echo. Here there's clear hypertrophy. Here you can see dilated cardiomyopathy. So usually these patients progress from hypertrophic cardiomyopathy to dilated cardiomyopathy. And here you can see inverse T waves, which it is usually seen in Friedrich ataxia. Some less common neuromuscular diseases associated with cardiac manifestations. Periodic paralysis. It may be due to hypokalemia, normal kalemia, or hyperkalemia. What you need to know is that the lesser the potassium level, the worse for the patient. Most of these resolve when you replete potassium, but the hyperkalemic may get worse if you replete potassium. Then in these patients, try to give mexiletine. It will help them out. And for the weakness, you can give them acetazolamide. This is autosomal dominant. That's why it is probably called periodic familiar paralysis. Since it's familiar, think of an inheritance pattern that may affect all the family. So one of these different diseases is the Andersen-Tawil. I will show you a picture of him. It is the long QT syndrome type 7, and it is a triad of characteristic dysmorphic features abnormal QT and ventricular arrhythmias. Here you can see him low set ears and